A 26-year-old woman with a history of autism spectrum disorder and borderline personality disorder lived in a supervised group home where staff administered all of her medications, including lithium carbonate and lamotrigine. Over 2 days, she began to feel increasingly ill. Nausea came first, then vomiting, then frequent diarrhea. As her symptoms persisted, group home personnel brought her to an emergency room. By the time she arrived, the vomiting and diarrhea had started to ease, but she still felt unwell and complained of ongoing nausea. About a day earlier, a clinician had checked her lithium concentration, and the result came back very high at 3.3 milliequivalents per liter. In the emergency room, the team expected that if this were severe lithium toxicity, she might show clear problems with thinking, coordination, or muscle control. They watched closely for confusion, agitation, tremor, unsteady walking, muscle stiffness, involuntary jerking movements, and worsening reflex changes. They also watched for heart and blood pressure problems. Because lithium toxicity can sometimes cause a slow heart rate, low blood pressure, or electrical conduction changes. But her bedside appearance did not match a severe picture. She was awake, calm, and able to answer questions appropriately. She was not confused and did not seem encephalopathic. She remained hemodynamically stable. Her heart rate was 96 beats per minute, her respiratory rate was 20 breaths per minute, and she had no fever. The neurologic examination offered one small clue, but not a crisis. Her reflexes in the lower extremities were brisk at 3+, yet she had no clonus and no muscle rigidity. There were no new tremors, no seizures, and no obvious loss of coordination. An electrocardiogram showed a normal sinus rhythm. The corrected QT interval was about 460 milliseconds, which the team noted and continued to monitor, but there were no dangerous rhythm changes. With the story of vomiting and diarrhea, the team focused on a common pathway to lithium toxicity that can happen even when someone takes exactly what they are given. When the body loses fluid and salt through gastrointestinal illness, the kidneys try to conserve sodium and water. Lithium is handled in similar pathways, so the kidneys can mistakenly retain more lithium too. The result is a rising lithium concentration and, at the same time, signs that the kidneys are under stress. They stopped lithium and began treatment with isotonic fluid replacement. She received 1 liter of 0.9% sodium chloride, then continued on an intravenous infusion at 100 milliliters per hour. The plan was to support her circulation, improve kidney filtration, and allow her body to clear lithium naturally. They also planned symptom control with anti-nausea medication as needed, and careful monitoring of electrolytes. A few hours later, the repeat lithium concentration returned lower, at 2.9 milliequivalents per liter. That trend was reassuring. Around the same time, her kidney function showed a mild acute kidney injury, with a creatinine concentration of 1.52 milligrams per deciliter. Even so, her mental status remained steady, and she had no worsening neurologic findings. She was admitted to the hospital for ongoing monitoring. Intravenous fluids continued. She remained awake and oriented, and she was able to eat and drink. The main complaint that lingered was nausea, but there were no cardiac issues and no new neurologic problems. As the team watched the numbers, they also watched her. In lithium toxicity, the most dangerous turning point is often not a single lab value, but a change in the patient's neurologic status or a failure of the kidneys to clear the drug. So they continued to reassess her mental status, strength, reflexes, and overall stability, while repeating lithium concentrations and kidney function studies. By the next morning, the laboratory trend continued in the right direction. Her lithium concentration had fallen again to 2.0 milliequivalents per liter. Her kidney function was improving as well. The creatinine concentration was down to 1.27 milligrams per deciliter, and the blood urea nitrogen concentration was 17 milligrams per deciliter. Her vital signs remained stable, and she had no deterioration in her neurologic examination. That is when the case reached the decision point that often divides teams: whether to use hemodialysis. Hemodialysis can remove lithium efficiently, and it is absolutely life-saving for patients with serious neurologic toxicity, seizures, life-threatening rhythm problems, severe kidney failure, or lithium concentrations that rise or fail to fall despite aggressive supportive care. But it is not a benign intervention, and in chronic lithium exposure, the patient's symptoms and clinical course carry heavy weight. A medical toxicology consultant reviewed the situation and emphasized the direction of travel. She was clinically well, her lithium concentration was steadily decreasing, and her kidney function was recovering. From that perspective, the most important treatment remained stopping lithium, continuing isotonic fluids at a higher rate when safe, replacing electrolytes as needed, and monitoring closely. The consultant advised that hemodialysis would not typically be expected in an asymptomatic patient who was clearly clearing lithium. Even so, hemodialysis was recommended by another service based on the lithium concentration. An attempt was made later that day. She struggled to tolerate the experience, in part because of the distress and sensory strain it created for her autism. After about an hour, the session was stopped. The team returned to supportive care, which had already been working. Intravenous 0.9% sodium chloride continued at a higher rate, about 200 milliliters per hour, with ongoing monitoring to ensure she did not develop fluid overload. Her mental status stayed normal for her baseline, and she remained hemodynamically stable. Several hours later, her lithium concentration fell further to 1.3 milliequivalents per liter. She remained asymptomatic. With the lithium concentration continuing to decline and no neurologic changes, the plan became simple again. Keep supporting kidney clearance with isotonic fluids, repeat laboratory testing the next morning, and continue observation until the lithium concentration returned to the therapeutic range, and she felt back to normal. In the end, her course told a consistent story. This was most consistent with chronic lithium toxicity triggered by gastrointestinal illness, dehydration, and a mild acute kidney injury. She did not develop the severe neurologic findings that make lithium toxicity so dangerous, and her laboratory values improved in the same direction as her clinical condition. The takeaways are practical and memorable. Lithium toxicity can happen without an overdose, especially when vomiting and diarrhea cause dehydration. The best early treatment is often the basics done well: stopping lithium, giving isotonic fluids, treating nausea, monitoring electrolytes and kidney function, and repeating lithium concentrations to confirm a steady decline. When the numbers fall and the patient remains neurologically intact, supportive care is usually enough. Hemodialysis remains a powerful tool, but it is best reserved for the patients who show clear signs of severe toxicity or who cannot clear lithium because their kidneys are failing.